Good morning, everybody. Thank you for joining me here today as we talk about heart failure and the opportunities to clarify documentation and again tell the accurate patient story so that we can capture the appropriate codes that really reflect the intensity of resources that the hospital expended to take care of the patient. So thank you again for this conversation. This is a disclaimer statement that is common for every presentation I give. Every effort has been taken by the author of this presentation to ensure that the information shared was as current as possible at the time it was developed and presented. The primary intent of this presentation is to be informational only and to share it in a manner that is more relatable and understandable to those in healthcare with various backgrounds and levels of experience. The information that is shared is only intended to be just that, informational, and is not to take precedence over any state, local, and or federal guidelines, organizational policies, and or procedures. The reason why we're going to talk about heart failure today is because it is the second most common inpatient diagnosis for the Medicare population of patients. This diagnosis is one of 5 diagnoses included in the Medicare Pay-for-Performance programs. Here's some documentation improvement opportunities that are specific to heart failure. Document the acuity and the cause of the heart failure. If there is a cause, then it must be documented in order for the coder to be able to capture the greatest specificity of codes and therefore the appropriate reimbursement for the facility for the resources used to care for the patient. So, for instance, if the heart failure is due to CAD or uncontrolled hypertension, then that needs to be documented, that cause and effect relationship. What is the acuity of the heart failure, such as is it acute, is it chronic, is it acute on chronic? The type of heart failure is critical. Does this patient have diastolic heart failure, or is it systolic heart failure? Do they have combined systolic and diastolic heart failure? If the term left ventricular heart failure is used, then there is further clarification needed to be documented by the attending provider as if this is systolic or diastolic. Once again, ensure there is documentation that is specific as to regards to if there is a cause and effect relationship. Link the documentation to any other related condition caused or again related to the heart disease, such as hypertension and kidney disease. If there is documentation of the acuity and etiology in a consultant provider's note and is not reflected in the attending provider's note, then a query will be sent to the attending provider to clarify. Again, any type of heart disease, such as coronary heart disease, we need to specify the stage and the acuity of CHF. Also, document the BMI. There are some terms that we use in our documentation that do not translate to codes. These are 2 of those terms: decompensated heart failure and compensated heart failure. If decompensated heart failure is documented, the attending provider must use clarifying term that reflects that the heart failure is acute heart failure and also specify the type, such as systolic or diastolic. If the term compensated heart failure is documented, the attending provider must clarify that the term reflects that the heart failure is chronic and also specify if it was systolic or diastolic. The term heart failure can be used to qualify as either a major complicating or comorbid condition or a complication or comorbid condition. This really just depends on how the attending provider is documenting. And also remember that the addition of an MCC or CC adds to painting the picture of how sick the patient is and speaks to the resources used to care for this patient. I'm going to show you two classification systems that are used by cardiologists when they want to delineate the extent and the severity or the severity of the heart failure of the patients that they're treating. One is the New York Heart Association classification system, which is shown here on this slide. This slide here, the American College of Cardiology American Heart Association classification system, is used by cardiologists to assign stages with various stages of heart failure. This set is used by coders for the assignment of diagnosis codes for the heart failure. There are some things to be remembered because medicine is not certain, right? It's a process of working up diagnoses. And so I just want you to be aware that it's appropriate for the attending provider to document possible, probable, or suspected. If these terms are used in terms of coding, the condition will be coded as though it existed or was established. Again, is to be reflective of the resources of the hospital that were used to work up a condition, to evaluate a condition, testing, all these conditions that required extra monitoring, extended length of stay, increased nursing time. So that's the reason why these are allowed to be coded as they existed to the patient account, is that because it reflects the resources, the intensity of resources used to care for the patient. The provider needs to document the presence of a cause and effect relationship if it existed, and sometimes there'll be clarified language if the coder is unsure if there's a cause and effect relationship. So just to get ahead of it, if there's specifically not one and you know it, then please document that. Um, Again, if there's documentation of the acuity and etiology in a consulting provider's note and it's not in the attending provider's note, then a query will be sent to the attending provider because that's the cause and effect relationship affects the code assignment for this patient account. And documenting ahead of time will save the provider from a query. It is important and critical to document the provider thought process in terms of monitoring and the treatment plan. This will also help to justify the medical necessity of keeping a patient in an inpatient status in an acute care bed. If there's no medical necessity to justify the inpatient status in an acute care bed, the hospital does not get paid. So this is just an example of how the specificity and the clarification to obtain the increased specificity of the type and acuity of heart failure to justify coding to the highest specificity of quality indicators such as severity of illness and risk of mortality are more accurately captured to reflect again the resources that were used to care for the patient and also really tell the picture of how sick this patient is and why they needed that intensity of resources. Again, um, it does not change the care that the patient gets, but what this does, it increases the quality of documentation to increase the continuity of care. The documents a complete and accurate picture of the patient. It increases the clarity of documentation needed to support the medical necessity for inpatient status in the acute care bed. Here we have three different examples of how the clarification of the specificity of the type and the acuity of the heart failure changes the relative weight. So once again, please remember the relative weight times the hospital base payment rate equals what the hospital will be paid for the care of this patient. So as you can see, we go from relative weight of 0.5541 with the severity of illness 1 and risk of mortality 1. And then when we increase through clarification the specificity, type, and acuity of the heart failure, we get a relative weight increase to 1.2285 with the severity illness 3 with the risk of mortality of 3. That more than doubles the payment to the facility. And more than that, it actually reflects the intensity of resources needed to care for this patient. And we need to receive reimbursement to cover that intensity of resources. Again, it's about keeping the hospital doors open. As I said, it's really about obtaining the reimbursement to care for the intensity of resources of caring for these patients. If there's no money, there's no mission. And if we want a place to carry out the mission, then we have to work as a collaborative team. This is my first page of references that I used when I developed this presentation, so I hope that you find them helpful. This is my second page of references that I used and sources. Again, I hope you find them helpful. I have resources I use because I'm a nurse that also, in addition to my clinical life, also obtained a coding and other revenue cycle experience that I've been able to add and share. And that's what I really hope to do, is just share information so we're all on the same page. I want to thank you all very much for taking the time to listen to this presentation, and please share any comments at my email down below. My goal is to provide, share, and encourage the exchange of information across the many silos that exist in a healthcare setting. My belief as a healthcare professional is that we are all one team that all share the common goal of providing care to the patients in need. It wasn't until I got to the business side of healthcare that I really wanted to be able to affect the resources that I was able to use and needed more expansion of to take care of the patients at the bedside. And I realized how we all play a part in working together to obtain the appropriate reimbursement and so that we could grow our service lines to really address the needs of a population of patients that are really in need of care and more advanced care that we are able to provide. Thank you all very much, and thank you for participating today.